So my name is Professor Julia Downing. I'm the Chief Executive of the International Children's Palliative Care Network, and I'm also a Professor in Palliative Care working at Makerere University in Uganda, at the University of Belgrade in Serbia, and at several universities in the UK. I'm also linked to the Worldwide Hospice and Palliative Care Alliance, as I'm on their board, and I'm on the board of the International Association of Hospice and Palliative Care. So I'm bringing quite a broad international perspective. So I'd like to share some of the different models in palliative care that we've come across in different parts of the world, in different countries, and think about how they are integrated into the system. I think one of the key aspects of any model of palliative care is that it needs to be appropriate for the health system in which you are working and in the cultural context in which you're working. So some of the different models that we've experienced are hospital-based palliative care, where you might have a specialist palliative care team of maybe a nurse and a doctor, maybe a social worker, and they are working as a consultation team throughout the hospital. They don't take over the care of patients, but they support the care of the individuals, providing expertise in palliative care and working with, for example, the oncology doctor or the renal doctor to provide palliative care, and working with the other nurses and professionals in the hospital to provide palliative care. So an example, in Uganda at Malago Hospital, they have a palliative care team, and then they have trained link nurses on the different wards. And so those link nurses are able to provide palliative care at the generalist level, providing initial support and pain management. And then when the patients get sicker or they have more complex needs, they are able to share the care with the specialist palliative care team. So that's one model. We've also seen models of hospital palliative care where there isn't a specialist team, but there's a group of health professionals working in the hospital to provide that palliative care system. And both of those models are quite integrated into the healthcare system, with referrals to the community teams, with referrals to other hospitals. So making sure that it is an integrated system with clear referral pathways, so the individuals can get care in the hospital, but also then when they go home, and they can be referred to a community team if they exist. So another model of care would be that of the community teams. In some countries we have experience of the community teams being the community health volunteers, nurses working in the community, again providing palliative care more at the primary health care at the generalist level, linking into specialist teams where they are appropriate. We've also seen models of care in health centres, where they have palliative care individuals working in the health centre, and again taking in referrals from other communities and from other health centres. So there are a variety of models of palliative care available, both for the care of adults but also for care of children. And then alongside that is the more specialist systems, such as Hospice Africa Uganda, in Kampala, which is an NGO providing specialist palliative care, working very closely with the government and with the other systems. So there are different models will work in different places, and as I said, it's very important that the model is appropriate for the context and for the culture in which they're working. One of the developments in Uganda since 2004 has been nurse prescribing. And so we have specialist trained nurses and clinical officers who are able to prescribe analgesics such as oral morphine and the strong analgesics. This has been going on since 2004, and we have nurses who are trained working in different parts of the country, some working very much on their own, some in the community, some in hospitals. So what's happened recently in the past year is that we've been able to undertake an evaluation of that nurse prescribing. So we had a study which was done through a protocol developed by the African Palliative Care Association, Hospice Africa Uganda, Makerere Palliative Care Unit, the Palliative Care Association of Uganda, the Ministry of Health and the WHO. So a collaborative project. It's been done in 3 parts. The first part was about looking at the training and agreeing the core competencies for prescribers and making sure that the training equips the nurses with those competencies. The second part of that evaluation was we had 22 nurses working around the country all seeing 20 patients, hopefully for up to 3 visits, and documenting the care that they were given, documenting the pain assessment, pain management, and also utilising the African Palliative Outcome Scale on 3 consecutive occasions to see if there was any improvement in different aspects of care, specifically in pain management. And within that, we've been able to show that the nurses are competent to prescribe, they are managing individuals' pain well, and we've seen a significant difference in pain improvement. We've also then looked at the third part of that evaluation, was looking at the context in which the nurses were working. So trying to look at if a patient's pain wasn't managed, was that because the nurses couldn't prescribe, or was it because they didn't have access to the medications? So we've done a rapid appraisal of the health system, and we're tying in the 3 components of that evaluation to write up a paper to show that nurses are able to prescribe, they're able to do it competently, and very importantly that they know their limits and they know when they need help with more complex cases, and making sure that that help is put into place. So that's a really important piece of work that we're just completing, and it's a piece of work which will be used hopefully not just within Uganda but regionally and internationally, which demonstrates that where properly trained, palliative care nurses are able to prescribe those strong analgesics such as morphine. So we're really excited by the results of that study. Another area of great concern is that of children's palliative care. We've recently, the International Children's Palliative Care Network, completed a study which shows that over 21 million children around the world need access to palliative care services, and at least 8 million of those need access to specialist palliative care services. And yet we've also looked at the gaps, and we found that less than 5% of children actually have access to those services. So there are many gaps around the world in terms of children's palliative care, particularly in some of the low and middle income countries, and particularly in the countries where HIV is a big problem, as that has obviously increased the number of children who need access to palliative care. And so we're trying to work with different palliative care organisations in the region and nationally to support the development of children's palliative care in different parts of the world. Specifically focusing on those areas where there's a high need and yet there's low service provision. But of course that has challenges, because if there's not much service provision, how do we train health professionals? It's all very well giving them the theoretical basis, but they need to have access to clinical placement sites so that they can see children's palliative care modelled in practice. And so providing education is a challenge, but it's a key area that we are looking at, and there are different ways of providing that training. But it's not just about training, it's also looking at do people know what palliative care is for children? Is there a need for children's palliative care? I was working with one government who said, we don't need children's palliative care, it's not an issue for us. But when we did the needs assessment, we were able to demonstrate that there is a need in that country. So advocacy, information, sensitisation around what children's palliative care is and how children's palliative care can impact on the lives of children and their families is also a very key issue for us. And so in looking at developing children's palliative care, we have to look at the wider issues. Are there access to medications? Can you get medications for pain and symptom management or chemotherapy for the children? If you can get those medications, are they available in paediatric formulations? So access to medications is also another key area that we're looking at. And then supporting the implementation of children's palliative care and trying to see that integrated into the existing systems and the existing structures. And one of the things we found in doing that is that it might take longer if we're trying to get the individual governments, the individual hospitals to see the need and to develop the services. But in the long-term approach, it's more sustainable because we find that that is really integrated into the structures and into the systems. One of the issues in supporting the development of palliative care in different parts of the world are some of the cultural and social issues. For example, is it okay to talk about death and dying? is it okay to share with somebody that you don't think that they have long to live? Their prognosis, even in some cases their diagnosis, and who is responsible for telling them? Is that a family member, or is it the health professional? So there are different cultural issues in different countries. There are also different issues around access to medications, around the utilisation of medications, around the utilisation of access to healthcare. Sometimes if individuals are not diagnosed until they're quite late on in their disease progression, or they're not taken to the hospital, they then get taken to the hospital and not long after they die, and so therefore the next person who's very sick doesn't want to go to the hospital because they're seen as somewhere where you die. So some of these issues can be challenging for us in palliative care. So there are various myths, myths about what palliative care is, myths about the use of morphine as an analgesic, myths around the issues of pain in children and pain in adults and how we manage pain. So there's quite a lot of work for us to do in different contexts, in different cultures and settings with regards to breaking down some of these barriers, breaking down some of these myths around palliative care, so that we can then sensitise people to what palliative care is. We can work with the healthcare professionals, we can work with the media, we can work with those who regulate access to medications to break down some of these barriers so that we can then get access to medications, we can get access to palliative care for individuals who need it. And not just adults, but for children, for perinatal and neonatal palliative care, as well as for the elderly. Issues in dementia, providing palliative care for people with dementia is a big issue. So there are many different aspects to the cultural and societal barriers to palliative care that we as advocates for palliative care need to be working on. So in 2014, the World Health Assembly passed a resolution on palliative care. This was the first time there was such a resolution passed at the World Health Assembly. And this resolution has been helpful for us in terms of advocacy. So all of the member states signed up to this resolution, and within the resolution it talks about the provision of integrated palliative care across the lifespan, across diseases, ensuring access to palliative care education for health professionals, and a whole spectrum of issues including access to medication. So we have this resolution which we can then use as an advocacy tool within the different countries. And we have found that particularly helpful for us as a way in to the governments in different countries as we go to follow up with them and see how they are managing to implement that resolution and how we can help and support them in that. Now, it's only a couple of years since the resolution, and we have found that in some countries there has been quite a lot of progress. In other countries they are still trying to get their head around what the resolution is, what it means for them and how they can implement it. So for us working in the development of palliative care, we have been utilising the World Health Assembly resolution within our advocacy, but also thinking about some of the other issues such as the Sustainable Development Goals and such as universal health coverage. And how do we use those terminology, how do we use the resolution to try and work with governments and with key stakeholders in countries to really promote palliative care and to support them in the development of palliative care. So this is an ongoing work that we are doing. We feel that the resolution has been beneficial, it has been impacting on the development of palliative care, but there's still a long way to go in a lot of, the majority of member states. And so we're still working with governments, with stakeholders to support the implementation of the WHA resolution.